Hey guys, so today we are going to learn about the esophageal perforation. So quickly I am discussing this. So it is due to mainly two reasons: direct trauma to the esophagus, or it can be spontaneous. So in trauma we know that either it can be iatrogenic or really any accidental trauma. So iatrogenic is the most common one here, as it is due to mainly the endoscopy and the main part of the esophagus that is perforating is cervical esophagus. So now in trauma most common is iatrogenic one due to endoscopy. So we are going into the treatment part of it. You can do the conservative management if following criteria will be met. So either it is due to flexible endoscope and cervical esophageal injury happen, or if the thoracic, then mediastinal pleura should be intact, and esophageal dissection should be there, means partial tear, not complete tear, and septic load should be low. So if this 5 criteria met, means flexible endoscopic injury to either cervical or thoracic, then mediastinal pleura should be intact and the perforation should be partial with low septic load. Then you can do the conservative management, and if not, then we have to do the repair via endoscopy or by surgical. In endoscopy you can do clippings, clutters, or self-expanding metallic stents. And you can see the double barrel sign in case of endoscopic esophageal dissection. So up to this was the iatrogenic injury to the esophagus, and mostly due to endoscopy. So most common cause is iatrogenic and cervical esophagus, and due to endoscopy. Okay. Now, Boardhouse syndrome. Boardhouse syndrome and Mallory-Weiss tear both are due to the barotrauma and spontaneous tear. So, now quickly learning the pathophysiology part. So, Boardhouse syndrome is due to barotrauma. And why does barotrauma is happening? Due to vomiting or retching against the closed glottis, means cervical sphincter is closed and we are trying to vomit or retch against the closed glottis. So pressure is highly increasing into the esophagus. So esophageal perforation will happen. Now what kind of perforation? So mainly it is a longitudinal tear in left lower esophagus, and all layer perforation will be seen. And here in Mallory-Weiss tear, what is seen, it is also due to vomiting rupture, but against, so Mallory-Weiss tear is in the stomach part, and so here the junction will be gastroesophageal, and here it is due to cervical sphincter. Okay. And here same, the longitudinal tear will be there, but only the partial thickness tear, means mucosa and submucosa are only getting torn, and here the perforation will be full thickness, all layers are getting involved, and here it will be in the left lower esophagus part, and here it is in the right cardia. So these are main the difference. that Mallory-Weiss tear and Borhaus syndrome both are due to barotrauma, means we are vomiting or retching against the junction which is closed. So in case of Borhaus syndrome, it is due to the glottis, means cervical sphincter is closed, and in stomach the gastroesophageal junction is closed. So in both case pressure are rising, but the site is different, so the tear will be also different. In esophagus it will be full thickness tear and mainly the left side, left posterolateral, okay. And here it will be right cardia just below the JE junction usually, and partial thickness tear, so mucosa and submucosa getting involved, okay. Now here it will be a Mackler's triad, that is more important to learn. So three things: retrosternal chest pain will be there, which is radiating to the shoulder and jaw, vomiting and raging history, and surgical emphysema, means air in subcutaneous plane. So these three things: air will be there, pain will be there, and history of vomiting or raging. And in case of pneumomediastinum, which is happening here, Haman crunch will be audible in auscultation, means we are auscultating, we are hearing sound in our stethoscope. So heartbeat will be here, but an air crunch will be also audible due to pneumomediastinum. Done? Now how will you manage this patient? So in first investigation, overall CECT is the best investigation, so investigation of choice. But first we can do X-ray and we will see the pneumomediastinum and surgical emphysema. So both signs we have to learn. What are the signs of pneumomediastinum? So continuous diaphragm sign, Necklerio V sign, and spinacal cell sign, which is unilateral, and if bilateral we can say angel wing sign. Sorry for the spelling mistake, it should be angel, okay. So angel sign and bat wing sign. While in surgical emphysema we will see air in subcutaneous space, so Ginkgo leaf sign, okay. And contrast study are best for the identifying the leak, and iohexol is the best contrast, and barium swallow is slightly contraindicated because it can cause mediastinatitis. And treatment is obviously full thickness, so we can't do management conservatively or medical management, we have to treat it surgical, and less than 24 hours is the golden period. So we will do thoracotomy and left posterolateral, cause this is the most common site, and we will do primary closure of tear, then thoracolavage, drainage, and finally close by Vicry's suture.